Morning, everybody, and welcome to this session that's focusing on the theme of restoration or revolution following the pandemic. Today, we're going to be looking at what we can learn from historic shifts in services in the wake of disaster. Many of you delegates will have attended our previous Nuffield Trust Summits, and it's fantastic to have you back. But for those of you who've not attended before, and it's brilliant that we can get so many more people now that we can do this online, we welcome you and our wider audience. For those of you who don't know us, the Nuffield Trust is a health policy think tank, and we look at a wide range of issues relating to health and social care policy. With our summit, we try and provide people who are working in healthcare and policy the opportunity to sit back and reflect a bit more on some of the big issues of today. So I'll come on to this morning's session in a moment, but this afternoon, we've got a panel session starting at 2 o'clock. We've got Partha Carr from NHS England and Improvement, Dr. Hannah Barron-Brown from the Women's Equality Party, and Adam Lent from New Local, and that's going to be chaired by Richard Humphreys, and they're going to be focusing on how public services, health in particular, but perhaps broader than that, can make change happen rapidly. Tomorrow, we're going to hear from Scott Greer from the University of Michigan, and he's going to be talking with colleagues about centralisation and decentralisation. So he'll be with Sarah Pickup from the Local Government Association, Rob Sargent from Optum, and Layla McKay from the NHS Confederation. We're really grateful to everybody involved in making this happen. We've got sponsors, MSD and Optum, our media partner, the BMJ, and the fantastic Nuffield Trust events team, supported by Glasgow's, who are working behind the scenes to make this event happen and bring it to you so successfully. But let's focus on this morning now, and I'm really delighted that we've got Abigail Woods with us today. Abigail is a Pro-Vice Chancellor and Head of the College of Arts at University of Lincoln, but she began her career as a veterinary surgeon before she retrained as a historian of modern Britain. One of our principles at Nuffield is that there's almost always something that we can learn from history when we're making policy recommendations about the future. And although coronavirus may have been the worst pandemic of modern times, it's certainly not the first experience we've had of the significant impact that disease and other bad things can have on the way in which healthcare and wider public services are delivered. So over the next hour, Abigail's going to give us some insight into past events so that we can use that learning to help us shape our thinking about the future. This session obviously is live streamed, you're watching it now, but it's also going to be being recorded, so that you can watch it again in the future and recommend it to your colleagues. We will have a Q&A session, so Abigail's going to speak for about half an hour and then we'll move on to questions. So please use the Q&A box to submit questions as you think of them as we go along. Nadia Krellin, who's one of my colleagues, a fellow at the Nuffield Trust, is going to be moderating the questions, and she'll summarise those questions that come in from the box for us. I also just want to warn you that, of course, as with every conference, we will send you a link to a survey to get evaluation at the end of this session, and we'd really appreciate you taking a few minutes to fill this in. And finally, before I hand over to Abigail, just remember to tweet throughout the session if you do tweet using the hashtag #NTSummit. So with that, I shall hand over to Abigail to talk us through what history can tell us about disaster and the way that it helps shape public services. Thank you, Abigail.
Thank you very much, Helen, for that kind introduction and for the invitation. It's a great privilege to have the opportunity to bring a historical perspective to your considerations in this summit. The next slide, please. So I've been asked to speak to the question of how seismic events can lead to radical changes in how public services are delivered. And I've decided to address this question by looking at three contrasting case studies of historical health crises. And I'm going to look at the various ways in which they changed or didn't change matters such as healthcare structures, health policies, disease perceptions and behaviours, and understandings of who was to blame for the problem and who was responsible for sorting it out. Next slide, please. And we're going to start right back in 1831 with the first of what was to be several epidemics of cholera to affect Britain during the 19th century. The 1831 to 32 epidemic was part of a wider pandemic that swept westwards across Asia. It appeared first in Sunderland in October 1831, spreading to Newcastle and Scotland, and then onwards the following year to London and the rest of England. In retrospect, we can see that it was the movements of infected people and also the movements of barges and ships that were discharging infected excreta into waterways that allowed cholera to spread. But at the time, it wasn't recognised as a waterborne illness. Cholera often struck without warning to produce shocking symptoms that progressed with terrifying rapidity. Healthy adults were affected as much as the old and the very young. Victims suffered massive vomiting and diarrhoea, resulting in a comatose, apathetic state, as shown in this image here, with sunken eyes and blue-grey skin. Around half of the infected individuals died, and altogether 32,000 people lost their lives. And I think it's interesting that when we compare that to the size of the population at the time, we're looking at a similar loss of life, proportionately speaking, to in the current COVID epidemic. Next slide, please. Poor areas were particularly affected. And again, in retrospect, it's easy for us to see that that's because of the worsening sanitary condition in British towns. This was a period in which industrialisation was progressing rapidly, displacing rural cottage industries and leading to urban migration, overcrowding, and inadequate water supplies, sewerage, and sanitation. But at the time, as historian Richard Evans has pointed out, the idea that poor sanitation, overcrowded housing conditions, and lack of pure water supplies were to blame was seldom expressed, still less the belief that it was the responsibility of government to put these things right. Some observers attributed cholera to divine retribution. It was widely held that the poor had only themselves to blame, because they were idle, immoral drunkards. And this poster on the right really brings that home by explicitly connecting drunkenness in Gateshead to outbreaks of cholera several days later. To prevent the disease spreading, a central board of health was formed along with 1,200 local boards of health. And they executed quarantine regulations that had their roots in 16th century measures to control outbreaks of bubonic plague. Cordons sanitaires were erected around infected areas to limit the movements of people and the conduct of trade. Diseased people and their contacts were quarantined at home, or the disease might be removed to an isolation hospital where they often died. Of course, these measures were particularly targeted at the poor people in the poor areas, whereas richer people were rather left alone. The clothing and the bedding of victims were burned, and if they died, their bodies had to be disposed of very quickly, in violation of social norms of mourning and burial. Like many other epidemics, cholera created social and commercial dislocation and brought to the surface latent antagonisms between different groups in society. The selective imposition of these controls on the poor, the destruction of their property, and their forcible removal to hospital at a time when food prices were high and people were already agitating for electoral reform and against agricultural mechanisation, resulted in riots, 72 riots in total, across various cities from England to Scotland. And there were conspiracy theories that cholera was a plot to kill off the poor and make their bodies available for dissection by medical students, a practice that had hit the headlines 3 years earlier with the case of Burke and Hare in Edinburgh. Next slide, please. So, as we can see in this image here, members of the medical profession were held particularly to blame for what was happening. This is a satirical print which has doctors on the left who are scaring the population with a cholera dummy. And some of the captions are referring to how much money they hope to make out of sending people to hospitals, isolation hospitals. So there was a great fear that these riots and the resistance of the poor could actually, compounded with all the existing unrest in the country, result in a political revolution of the sort that had swept across Europe just the year before, and which had there also been accentuated by cholera. And as a consequence, the state did relax its quarantine regulations. Next slide, please. Well, when cholera disappeared in 1832, there was a collective sigh of relief. The deaths were at an end, and the feared political revolution had not materialised. Controversial quarantine controls were no longer needed, and the boards of health were rapidly dismantled. The newspaper and periodical press quickly dropped the subject, and the medical profession had plenty of other pressing things to turn its attention to. Serious endemic diseases like fever and tuberculosis, which were themselves exerting a huge toll in urban areas. The leading Edinburgh Medical and Surgical Journal went so far as to say it wasn't going to review any new cholera publications. So whatever lessons had been learned did not seem relevant to, or at least to justify any expenditure in peacetime. Although cholera did return on several occasions throughout the century and with more lasting effects, this first epidemic in 1831 to 32 was generally seen as an exceptional event, and its departure spelt a return to business as usual. There was no significant legacy. So we'll move on now to a quite different case study. Next slide, please. And I think it's important when we think about health crises that we aren't bounded by species. As with COVID, many human epidemics originate in animals, and even those that only affect animals often have major implications for humans. And this is illustrated by the epidemic of cattle plague or rinderpest, which struck Britain between 1865 and 67. Rinderpest is highly contagious and very fatal. And apart from smallpox, it is the only disease that's been eradicated from the globe in 2011. In the middle of the 19th century, it swept westwards across Europe from the Eurasian steppes, where it was endemic. Two British vets went on a tour across Europe to study it in 1857, and they returned saying that there was really very little risk to the UK. But what they hadn't accounted for was the rapid expansion in cattle movements that the development of railways and steamships were making possible. By 1865, Britain was importing 120,000 cattle a year from all over Europe, and more than 60% of them were landed in London. It was in June 1865 that an unfamiliar disease was spotted in London dairies and quickly diagnosed as the cattle plague. By the time it was eradicated from the country, just over 2 years later, 420,000 cattle had lost their lives, which was 7% of the entire national herd. But in the great dairying county of Cheshire, 2/3 of cattle were lost. And this is one of several gravestones that farmers in that part of the world erected in memory of their substantial herds that had all been wiped out on account of the disease. Next slide, please. Although cattle plague was quickly spotted and the government was informed, no action was taken for a couple of weeks. And by then, of course, many cows had died and others had been rushed to market to try and realise their value. And they took the disease with them. When the government did act, it introduced really quite light touch measures. It allowed, but did not compel, local authorities to inspect cattle sheds and markets for diseased cows, to impose restrictions of cattle movements in areas where the disease had been found, and if thought necessary, to slaughter affected cows. But no compensation was paid, so clearly this measure was not particularly acceptable. The view of most farmers and landowners at the time, and that includes the sizable number of landowners who then sat in the House of Commons and the House of Lords, was that cattle plague arose spontaneously. 1865 was a time when the idea of the germ theory was only just coming into being, and it was widely held that most diseases under certain conditions could just appear and could then spread by contagion. So this theory, it's not surprising this theory was bought into in the case of the cattle plague. The disease did sometimes appear in areas where there was no history of contact with infected animals. But if a disease arose spontaneously, then trying to control it through inspection and movement restrictions wasn't believed to be particularly effective. Those measures wouldn't stop the disease from generating in the first place. So measures were widely evaded, they were widely opposed, and they were not enforced with any degree of severity. And so the disease continued to spread. Next slide, please. In 1866, the government appointed a royal commission to consider the situation. It recommended much tougher measures: a ban on livestock movements except under licence, like this one, which is shown here. Controls on the importation of stock from infected countries, and compulsory slaughter of diseased stock with the payment of compensation. But that didn't appeal to a government that was wedded to free trade, the sanctity of private property, and self-help, and which had rejected only in 1864 proposals to apply similar, though less stringent measures to other contagious diseases that existed at the time. There was also a fear that controls of this kind would impact on the food supply and discourage personal responsibility for the control of infection. Only in March 1866, when the disease was running rampant and it was quite clear that nothing was working, was the government persuaded to act and introduce these so-called stamping out measures via a new Act of Parliament. It also created a new temporary, so it thought, cattle plague department under the Privy Council to administer these measures. The feared food shortages did not emerge. Instead, the existing small-scale railway trade in diseased meat, railway trade in dead meat and milk was expanded. Livestock were increasingly slaughtered near the point of production, rather than, as was the tradition at the time, near the point of consumption. Meat was sent to cities on the hook rather than on the hoof. And in London, milk formerly supplied by dairies that were embedded in the city or just surrounded it was supplemented by supplies sent from up to 200 miles away by the railway. By 1866, the quantity of railway milk that was entering London was more than 3 times that of 1864. These measures worked very quickly. The disease incidence began to drop quite rapidly, but cattle plague wasn't finally stamped out until September 1867. Next slide, please. The legacy of cattle plague was substantial. When the crisis passed, the food trade did not go back to the way it was before. The reasons were psychological as well as practical. Experience had forced the recognition that cities could feed themselves with dead meat and railway milk. In 1868, a new metropolitan meat market was erected at Smithfield in London, with space for unloading supplies of dead meat. Some former urban cowkeepers, like the one on the bottom left, entered into contract with milk farmers from outside the city, which meant that in London by 1871, the railway milk supply was 4.5 times what it had been in 1864. These changes all contributed to the de-animalisation of urban spaces. The replacement of scenes on the top left here with that on the top right, the meat market, rather than the livestock market. And for much of the 19th century, our cities were teeming with livestock, and the cattle plague really began to impact on that and to turn our urban spaces into a form that's more familiar to us today. Next slide. The cattle plague also had lasting effects on the perceptions of and responses to animal diseases. The fact that stamping out had worked established the legitimacy of state intervention for the purpose of livestock disease control, and it exploded that belief in spontaneous generation. The fact that measures had worked implied that if spontaneous generation of disease happened, it was only very, very infrequent, that the main method of cattle plague spread was through importation and contagious contact. So this shift in understanding of the plague implied that ongoing restrictions were justified. If it had been imported once, it could be imported again. And therefore, it was important to place controls on other countries that had the disease. After 1866, their livestock supplies were either banned entirely or had to be slaughtered at the point of arrival, with veterinary inspection occurring at all ports. And that had the knock-on effect of stimulating countries that wanted to send their livestock to Britain, which was a net importer, an important market, to take measures for themselves to control the disease. So in this way, the cattle plague stimulated the first steps towards an international system of livestock disease control, which was later formalised under the OIE, the World Organization for Animal Health. And what's more, stamping out brought about an unanticipated reduction in diseases other than cattle plague. Because livestock were no longer moving around the country, they were not spreading other diseases to each other either. And two diseases in particular, foot and mouth disease, which was then endemic, and another disease called contagious bovine pleuropneumonia. Both of them reduced significantly when the cattle plague measures were applied. And this suggested that the extension of those measures to these diseases could bring about a further improvement in the health of livestock. Gradually over the 19th century, and not without controversy, because these diseases were not as devastating in their effects as the cattle plague, stamping out measures were extended. New Acts of Parliament were brought into being, and that temporary cattle plague department was given permanent form as the State Veterinary Department and what is today the Animal and Plant Health Agency. And those stamping out measures continue to form the foundation of the British response to contagious animal diseases right up to this day. And as you might remember 20 years ago, the devastating epidemic of foot and mouth disease that struck this country, all of that has its roots in the epidemic of cattle plague in 1865 to 67. Next slide, please. Our third case study is perhaps one that is more familiar to you. And it relates to a different type of crisis, the effect of the Second World War, and what that meant for the delivery of medical services on the home front. Now, the Second World War was long anticipated, and that provided plenty of opportunity to plan. One major concern was the provision of hospital beds for the casualties of bombing. In the lead up to the war, the Air Ministry was predicting 25 casualties a day for the first 10 days. It thought that the Germans would just try and bomb the British out of their homes. And this would result in a need for 300,000 hospital beds in the very, very early stages of the war. Unfortunately, a survey of facilities conducted by the Ministry of Health revealed that the existing hospital system was chaotic, inefficient, and inadequate, with wide variation in the quality of services. There were then two main types of hospital. There was the voluntary hospitals, which were traditionally charitable, but had to start taking in paying patients in the interwar period because they were running out of funds. And the municipal hospitals, which were run by local authorities and had historic associations with workhouses and the poor law, and which were very much looked down upon by the independent voluntaries. There was little coordination between those types of hospitals. Many lacked diagnostic laboratories, X-ray facilities, operating theatres, and many of the buildings were old, poorly maintained, and deficient in heating and catering. And the image on the right of the Middlesex Hospital, as it looked at the outbreak of war, really gives an indication as to the extent of these structural problems in hospitals that had been erected sometimes over 100 years previously. There was also a big shortage of beds and of consultants, and no rational system of GP referral. Next slide, please. To address these problems, the government established at the outbreak of World War II an emergency hospital service, and it assumed the right to direct the work that was done under this service by voluntary and municipal hospitals, and it organised them and some other more specialist hospitals into a coordinated regional system, so that certain hospitals, mainly in the danger areas for bombing, would take in immediate casualties, and then they would be moved on to more specialist hospitals further out of the urban areas for recuperation or for more specialist treatment. In London, that meant that hospitals were grouped regionally, each group containing a teaching hospital and stretching up to 50 miles in diameter. It involved a redistribution of beds, of staff and resources, and a rapid creation of new facilities and new beds and new buildings or annexes to existing buildings. And it provided the entire hospital service of a taste of central control and rationalised care. In the event, of course, casualties were much lower than predicted. I think 60,000 civilians were killed and another 86,000 were seriously wounded as a result of enemy action, but that was across the entire course of the war. The anticipated initial devastation did not happen. But what bombing did was create additional damage to the hospitals that were already creaking at the seams. Next slide, please. The government began planning for post-war reconstruction in 1941 to 42, partly to try and raise morale. One of the outcomes, which I'm sure you're familiar with, was the 1943 report by Sir William Beveridge, the principal of LSE, which aimed to analyse the needs of society and devise a system to address them. Beveridge wanted to tackle what he called the 5 giants: want, disease, squalor, ignorance, and idleness. He advocated a comprehensive system of social insurance that would provide a universal healthcare system, as well as vastly expanded public housing, free and universal secondary education, full employment, and benefits for the poor. Its defining characteristic was universalism. Benefits and services would be open to all and used by all, and paid for by all working people via national insurance contributions. These proposals won huge public support. Next slide, please. As I'm sure you know, the legacy of this wartime crisis and wartime planning was the National Health Service. Under the 1946 NHS Act, control of the hospitals in England and Wales was shifted to 14 regional authorities, as depicted here on the right in a 1950 Ministry of Health publication. Each of these centred on a teaching hospital, contained a medical school, and each was capable of establishing an integrated system of specialists. GPs were absorbed into this system, receiving fees that were set and paid for nationally, and they acted as the gatekeepers to other health services. Another wartime measure, the creation of an emergency public health laboratory service, which provided free diagnostic services to general practitioners and support for public health doctors, was also incorporated into the NHS and lasted until 2003, when it was replaced by the Health Protection Agency. The NHS couldn't have happened without the war. It adopted the principles laid down by the Beveridge report, and it built on the centralised control and rationalised care provided by the Wartime Emergency Hospital Service. But it wasn't only a product of war. Policymakers, local authorities, hospital governors, and health professionals had known for decades that the existing system of health care wasn't rational or sustainable, but they couldn't agree on what to do about it. The interwar period had witnessed a whole succession of reports on the subject, from Lord Dawson's 1920 report on the future provision of health services to the 1937 Sankey report, commissioned by the British Hospital Association, to two BMA reports issued in 1930 and 1938, but there was simply no consensus about the role of the GP, the relationships between municipal and voluntary hospitals, and whether services should be run regionally or by the local authorities. The wartime changes added impetus to that long-standing desire for reform, but they still didn't make the shape of the NHS inevitable. Following the Beveridge report, the Wartime Coalition produced a white paper, a 1944 white paper on a national health service, but like earlier proposals, it became rapidly bogged down in politics. The deadlock was only broken when Aneurin Bevan took up his new position as Minister of Health in 1945 under Clem Attlee's newly elected Labour government, which was committed to a programme of nationalisation. He brought momentum, a fresh look at the subject, and he overrode stakeholder objections, resulting in the 1948 creation of the NHS. Next slide, please. So in conclusion then, what do these three case studies reveal about the effects of seismic changes on how societal expectations of public services are delivered? Well, I think you can see it's a bit of a mixed bag, really. Cattle plague produced seismic changes. Cholera definitely did not. While the impact of the Second World War was somewhat mixed. It prompted a new way of addressing long-standing changes. I think if we're trying to account for three such different outcomes, we need to consider the influences of three particular factors. Firstly, did the crisis create new insights into the cause of the problem? Well, with cholera, little was known about the disease to start with, and no more definite ideas emerged in the course of the epidemic. The fact that poor people were more likely to get sick just confirmed existing beliefs that it was their behaviours that made them vulnerable, and that the causes of cholera were individual, not structural. By contrast, cattle plague completely challenged pre-existing understandings, not only of that disease, but of others as well, and revealed how free trade policies and the need to feed expanding urban populations had left the nation vulnerable to imported contagious diseases. The Second World War didn't create any new insights into the causes of the problems with hospital services. Those were already very, very well known, but it did create less tolerance of them because of the threat that they posed to national security in wartime. The second question is whether crises created any new insights into the management of the problem. Cholera did demonstrate that state-imposed quarantine wasn't particularly effective and that it created quite a lot of unrest, but it didn't generate any new insights into the sorts of measures that might be effective and might be acceptable. By contrast, the cattle plague generated radically new ideas of how to control contagious livestock diseases effectively, and it substantially reshaped attitudes to state intervention in the livestock trade for the purpose of disease control. In enabling factional interests to be overridden and giving a taste of centralised control of hospitals, the Second World War did suggest new ways of addressing long-standing weaknesses in the delivery of health services. And it also changed attitudes, again, to state intervention in society and the economy, helping to explain why long-lasting changes could happen in that case. And the final question is, does the learning that happens in crisis situations have any relevance in peacetime? In the case of cholera, no, it simply didn't, according to contemporary observers. The impacts and the management of cholera were so different to any of the other health problems that were being experienced at the time that it was just treated as a one-off situation, an exception which, once it had been dealt with, could be quickly forgotten. Whereas cattle plague, enforcing the realisation that the country was vulnerable to the ongoing importation and spread of cattle plague, that crisis brought into being an entirely new system, a state veterinary system that still exists today. The learning of World War II did have relevance in peacetime, primarily because it related to a problem that was already recognised in peacetime, that predated the crisis, and for which there was an existing consensus on the need to act. And also because the war brought about those wider changes in society and the economy that created the desire and the opportunity to do things differently, resulting not simply in the NHS, but a whole load of other changes in those immediate post-war decades. So I'm not going to try and answer those three questions in terms of how they relate to the current COVID pandemic, because I think other speakers and members of the audience are far more qualified than me to provide the answers. But from looking back at history, I think these are the questions that need to be asked in order to gauge what the legacy of the ongoing pandemic might be for the future management of health and disease. Thank you.
Thank you so much, Abigail. Really interesting. There's certainly a lot there that I learned that I hadn't known before. I know Nadia's collecting in questions from the audience, and she's going to join us on the panel, as it were, in a moment. But just a question from me to kick things off. I was really struck when you were talking about cattle plague, and I'd never heard of cattle plague before, about the kind of slow start, but actually a very significant impact in the end in terms of the way in which particularly our food industry is organised. And I was also thinking about I haven't read the whole book, I have to admit, but what I've read about your book on foot and mouth, where I think you're suggesting that the actions that government took potentially had a bigger impact than the disease itself. And I wonder if you think generally, if you look at when bad things happen, whether disease or any other bad things, whether you think that the impact of government actions can actually have more of an impact on public services than the bad thing itself.
Yeah, and absolutely, and that, of course, is the challenge for policymakers, isn't it? Knowing that, it is that calculus between what the disease would do if it was left unchecked and what the measures will do in checking disease. Yes, in 2001, the foot and mouth epidemic there, 10 million livestock lost. We got rid of disease, but at what cost? But because the disease was got rid of, again, we haven't seen it for 20 years, you might say, well, actually, that was justified. It was short-term pain, but we've had 20 years of freedom. We haven't had to live with ongoing problems. So I think it's a really, really hard call in balancing those things. And a lot decides on how are you going to measure success? Who gets to decide what success is? Success from the perspective of an individual might be quite different from the perspective of someone who's looking across a population. So always very, very challenging question to ask, but an important one.
Thank you. Nadia, are you ready to join us with questions from the audience?
Yes, so thanks, Helen. We've been receiving lots of really great questions through the Q&A from delegates. So what I've just done is just pulled a few together for you. So we've had a question in from Sarah Reid from the Nuffield Trust. And her question is, are you optimistic that we'll learn any lessons from COVID-19, given the experience of history? And another one from Diane Peacock, who is a retired academic, has said, as a medical historian, what do you see as the key insights regarding infection prevention and control for today's pandemic?
Okay, so you're asking me to answer the questions that I said at the end I wasn't going to answer, because I'm sure there are people who are better equipped to answer those than I am. So I'll have a stab, but like I say, I'm sure people who are dealing with health policy today are far better equipped. I think where changes, long-term changes have happened, they tend to have been top-down. Obviously we see shifts in societal expectations and attitudes that might make top-down changes more acceptable than they had been before. But ultimately, big shifts do tend to come in the shape of government policy. And the important thing is, have we just got rid of that problem and it's gone away, or are we expecting it to be a long-term problem? And I think the consensus is that, COVID isn't going to disappear. We are going to have to learn to live with it in some shape or form, even with an effective vaccination programme, and therefore some form of ongoing measures are going to be needed, which makes it more likely that we are going to see a longer term legacy. The learning that we've had in the midst of the pandemic is still going to be relevant after the pandemic. I think there's interesting answers to the question of, we have obviously learned a lot about the disease, perhaps started thinking it was more like flu, and now we know it definitely isn't. So, and the wealth of scientific research that's gone on through the pandemic has really generated huge insights that we didn't possess a year ago. What have we learned from its management? And I think perhaps this is the thorniest question of all, because that's where the controversy has mostly played out in the midst of the pandemic. I think we can see a really successful vaccination programme rolling out, but of course lots of other measures have been rather less successful. And it comes back to the same questions of, were those measures always going to be unsuccessful, or was it the way that they were implemented that made them unsuccessful? So could track and trace have been made more effective if it had been run differently? And what would analysis of that question mean for if we had to run track and trace again? So I think, it really, and I'm sure there will be plenty of opportunities to take a deep dive into each of the aspects of the pandemic that we've lived with, and to really try and account for them, not in the heat of the moment, but a bit more dispassionately, taking all factors into account, and to produce some learning, which I think it will have a much longer term effect even if the crisis is over by Christmas because everyone's vaccinated. We are definitely going to see some longer term outcomes from this one.
Thank you. Nadia, I can see we've got a few more questions coming in.
Yeah, so we've got a question from Kate Ardern, who is a public health director from Wigan. Kate has said, it's fascinating to get Abigail's take on the historic role of local government in protecting and improving the health of the population, and what lessons can be taken into current national debate about the new National Institute of Health Protection and Test and Trace. And we also have a question from, obviously there's been a lot of comparing with the past events with the current crisis and the current pandemic. We also have a couple of questions around that from Leonora Mary at the Nuffield Trust, who said, were there elements of the current pandemic response that you saw coming or that seemed very familiar to you when viewed through the lens of these historic events? And in relation to that, another question around, so I've never heard of cattle plague, but there seem to be some parallels with what we've seen with coronavirus. So things like delays in taking action, government reluctance to take tough action, and public failure to comply with measures. Do we see a repeated pattern that's kind of emerging regardless of, in Britain, regardless of party or government? So just a few questions there.
Thank you. A historian called Charles Rosenberg wrote a few years ago now. He was actually writing about AIDS, but he did propose that there is this sort of standard pattern for epidemics, and he likened it to a play. He said, you start off with something that you don't know what it is occurring at the sidelines, and it's not quite clear how big it's going to be or who's really affected. And so epidemics start quietly. And then when there's a realization that there really is a problem here, there's a sort of, rapid rush to find out and define the problem and to try and work out what to do with it. And there's a whole load of sort of outpouring of effort and energy that goes into that. The third stage then is the sort of development of measures, which, often tend not to be effective at first and have to be tightened, and then maybe they're not effective and they have to be tightened again. And then he said epidemics tend to end with a whimper, not a bang. They tend to quietly fizzle out. And I think, applying that to various epidemics I've studied in history and to coronavirus, I think we can see that pattern playing out, absolutely. And I think, one of the familiar aspects for me is, epidemic diseases are always going to be political. And I remember early on the coronavirus, there's a lot of debate about, where is the science in this? And of course we need the science, but the idea that there is somewhere a sort of pure form of science that can translate directly into policy and give us the answers is simply unrealistic. That, that sort of interface, and I've studied that repeatedly in so many epidemics, which science, whose science, and how does it get translated into policy actions? And then how do those policy actions create a new situation that requires new scientific understanding? And that sort of loop and between the interface between science and policy is I found it particularly fascinating, the way it plays out over and over again. And yet we still have a very strong public perception that if we only abide by the science, we would know exactly what to do. And I think that the problem there is how the general public perceive of science, and what do we do to change that perception, because it's quite clearly never like that. I'll just briefly comment on the role of local government, and the 19th century really was the heyday of local government, and of course public health in particular was always located strongly in local government, and that went for animal health as well as human health. And huge developments and very positive, innovative actions occurred at a local level. But we have seen that ongoing displacement from local to central. And epidemics were important in that, because not all local governments had the same interests, so they didn't always act in the same way. They acted in ways that made sense to them. But if you're looking at a disease that crosses across boundaries, that's when the problems happened. And it is interesting, in the cattle plague, it was when central government applied blanket measures across the country rather than leaving it to the discretion of local authorities that we actually got somewhere, but that quite naturally left some local authorities very upset about the situation and feeling that they could have done things differently and better if they had been left in control. And again, that's a sort of dynamic that I think plays out repeatedly.
Brilliant. Thanks, Abigail. We've got questions flooding in now, so give us another couple more, Nadia.
Yeah, so one of the things that has come up a few times is around communication and public knowledge and social media. So one of the questions we have from Andrew Elder, who is a consultant physician, is the current level of public knowledge and engagement, given news media in general and social media in particular, is entirely different now than in the 3 excellent examples you provided. How do you feel that might influence the outcomes of this disaster? And then another point that we had was around one of the summit sessions last week was focusing on the role of communication with the public and examine the role of misinformation in the COVID pandemic. So we tend to think of misinformation and disinformation as a modern issue linked to social media. But you, Abigail, obviously touched on that, and when you spoke in the context of cholera, about the rise of myths and conspiracy theories. Do you think that misinformation is something that we will always need to combat?
Okay, interesting bunch of questions. Yes. Yes, obviously social media is a sort of something entirely new. I mean, when I was commenting on the foot and mouth epidemic in 2001, it was just at the time when people were beginning to use the internet, and they were beginning to form networks through the internet, and that was seen as something really novel then, whereas of course complete step change over the last 20 years in terms of people engaging. But people tend to be engaging, of course, very selectively, and I wonder whether when we look at it in that way, things are really so different. Previously people would engage through oral cultures rather than through writing, but they would still be in their own little echo chambers and their own little bubbles, which of course is very much a product of social media, where people hang out and talk with people who just reinforce what they believe anyway, to a large extent. So while we do have a way of getting more information out there and of engaging more people than ever before, the question of the sort of quality of that engagement is questionable, I think. And yes, in dealing with misinformation, well, it's tricky calling it misinformation, because often it's just people interpreting the world in a way that makes sense to them, in terms of their own worldviews, their own backgrounds, who they happen to hang out with, what they have themselves witnessed. So it's certainly historically we see a lot of examples of governments say, well, these people are simply ignorant, they don't understand, they simply need to be educated. Whereas actually when you dig deeper and find out what people are saying and why, it makes you can understand it. So I think it's more a question of engaging with why people believe what they believe, acknowledging that, and then thinking about how they could be shifted into believing something differently, not through a sort of patronising education campaign, but through dialogue. And I know we're seeing a lot of thinking along these lines in terms of how do we get more people vaccinated, but it's an ongoing historical problem as well. We have been trying to get people vaccinated since the middle of the 19th century, when it was first made compulsory, and there were a lot of objections.
Very true. I think we probably just squeezed the last questions in, Nadia. What do you think? Can we synthesize them?
Yes, we can. We have a question here from Emma Pitchforth, who's a senior lecturer at University of Exeter. And she has said, in my experience, historians are sceptical about the extent to which people or policy can or will learn from history. Should historians be closer to decision making, or is that too simplistic? And we have a question from Stephen Black, who's a chief analyst at Ask My GP. Do we need a visible crisis to create consensus that big changes are needed in healthcare? So does it look like COVID will drive any major changes? And that also relates to a question earlier from Richard Humphreys around the need for a Beveridge moment. Do you envisage such a moment will arise from the current crisis?
Thank you. Yes. I mean, the interesting thing about the Beveridge report is that the government at the time really disliked it. It was because the public was so in favour of it and got so angry when Winston Churchill gave a lukewarm response that actually, it had to be embraced and acted on. So, commissioning a report, as we know, is one thing. Deciding to actually do something about it is another. And I'd be interested to see if both of those things manage to happen. I'm not holding my breath. In terms of do we need a crisis? It's interesting, I'm now moving on to study endemic diseases, the history of endemic diseases in livestock. And by contrast, endemic diseases are sort of fairly neglected. They actually cumulatively have a much bigger impact on health than these intermittent crises. But because they don't come as crises, they don't get the same attention, they don't get the same research, they don't get the same publicity, they don't get the same momentum behind them. And so they remain endemic because they're not being tackled with the sort of same degree of the same impetus. So I think that there very much is something about a crisis forcing through changes which otherwise, would require a lot longer, if indeed they would ever have been likely to happen. The first point about learning from history is obviously something on which I could expound at length as a historian. I think the thing about history is it doesn't provide neat answers. And I think policymakers, quite naturally, lots of us like neat answers, don't we? And historians are very good at coming along and saying, it's a little bit more complicated than that. And have you thought about looking at things this different way? And we make things more difficult. We don't provide neat answers. And I think perhaps, historians absolutely hate being asked to say, well, what do you think should happen? Because history doesn't work like that. We can't just say it happened in 1832, therefore it should happen in 2021. It doesn't work like that at all. But on the other hand, I ended my presentation with questions. I think history gives us questions which we do need to answer in order to understand the present and the future better. So I think history does have things to offer if people are prepared to be challenged, to have their lives made a bit more difficult and to be made to think harder about questions instead of given answers on a plate.
Abigail, that's a fantastic point to end on, because that's exactly what we like to do in Nuffield Trust. We like to help people to think harder and think better. Really appreciate you giving your time this morning and your learning to us, and thank you to everybody in the audience who listens and asks questions as well. It's been a fantastic hour. So as I said earlier, we've got another session this afternoon that people can join us on with Richard Humphreys in the chair. Going to be thinking about those questions of change and whether or not we need a seismic moment to make change happen. Thank you again to our sponsors, to MSD and to Optum, to BMJ, who've partners with On Media, and to the team behind the scenes who work so hard to make these things happen. You will be able to watch the session on again very soon on the Nuffield Trust website, and tell all your friends about it as well. And as I said at the beginning, we're also going to post you a link to an evaluation survey. Would really appreciate your feedback, and look forward to seeing you again this afternoon and hopefully tomorrow as well. Thank you all.